Good morning, ladies and gentlemen. We hope you had a restful night and are ready for another insightful day. We begin day 2 with our oral abstract presentations session 2, chaired by Dr. Namal Ratnayaka, Senior Lecturer in Pharmacology, University of Sabaragamu. We invite the presenters to share their research findings and innovative ideas, and chairpersons to come to the head table.
Check.
Good morning to all of you. With my co-chair, Dr. Ruwanti Jayasekara, and myself, Professor Gayani Liyanige, would like to welcome all of you to the second day of the sessions of Clinpharm 2024. Before starting the proceedings, let me state few announcements to the presenters. You will be getting 7 minutes for your presentation and 2 minutes for your discussion. If you exceed the time limit, we will not allow questions. Please adhere to the time limit given, and the time is displayed in front of you. Please refer to the time when you are presenting. So with that, we'll move to the first presentation of the day. Association between development of atrioventricular blocks and reverse tick sign of digoxin effect in acute yellow oleander poisoning patients. Authored by Area Weber WMABW, Jayamana SF, Lokunarangode NC, Francis GR, Jayawardena P. Paper will be presented by Area Weber WMABW. Over to you.
Good morning, ladies and gentlemen. While thanking the organizers for giving me the opportunity, let me start with my presentation on association between development of atrial blocks and reverse tick sign of digoxin effect in acute oleander poisoning in patients in Sri Lanka. So as you all aware, yellow oleander or Tevitia peruviana poisoning is one of the commonest plant poisons in Sri Lanka as well as in South Asian countries. And it's grown as an ornamental tree in tropics and subtropics. As you can see here, the plant, the leaves, flowers, and the seeds contain a lot of cardiac glycosides, including thevitin A, thevitin B, thyroxide, thevitoxin, peroxide, and nerfulin. Peroxide is freely soluble in methanol and ethanol, and thevitoxin is easily absorbed in GI tract. So regarding the electrocardiographic and biochemical changes, bradyarrhythmias, including atrioventricular blocks, and hyperkalemia signifies the cardiac toxicity, while tachy and bradyarrhythmias both have poor prognosis. So in most of the patients, reverse tick sign of digoxin effect is also common in ECGs. Our objective of study was to determine whether there is any association between development of atrioventricular blocks and the reverse tick sign of digoxin effect appear in the ECG in acute oleander poisoning patients within the first 24 hours of admission. The study was conducted as a prospective descriptive cohort study at Teaching Hospital Batiklo, Eastern Province, Sri Lanka from 1st of July 2022 to 31st July 2023. And all the patients following acute oleander poisoning admitted to medical wards, coronary care units, intensive care units, and Teaching Hospital Batiklo were included in the study according to the inclusion criteria. And the ethics review was granted by Ethical Review Committee of Faculty of Medical Sciences, University of Jawadhanapura. To be included in the study, if a patient is admitted to the study hospital with the history of yellow oleander poisoning and is having any symptoms and signs suggestive of systemic oleander poisoning, which includes bradycardia less than 60 beats per minute, and presence of reverse tick sign of digoxin effect in the ECG, or else systolic blood pressure is less than 80 millimeters per mercury, or else if the patient is having symptoms and signs suggestive of nausea, vomiting, abdominal pain, or diarrhea, we are included in the study within 2 hours of the admission. If the patient is below 16 years of age, if the patient is a pregnant woman and having a history of ischemic or valvular heart disease or having any significant cardiac disease, were excluded from the study. Apart from that, if patient is having history of co-poisoning with any other pharmacological agents which affect the heart rate and rhythm, were excluded from the study. If patient were already on medication which affect heart rate and rhythm, were excluded from the study. And also, if the patient has been already developed first degree, second degree, or third degree AV blocks on admission, they were excluded from the study. So eligible patients were recruited within 2 hours of admission according to our inclusion criteria, and informed written consent was taken. Their demographic data, incident history, past medical history, all were taken. The blood was collected for blood serum creatinine and serum potassium on admission every 6 hours early for first 24 hours. And we have taken serial ECGs on admission every 4 hours early for first 24 hours and monitored. Regarding the results, we have recruited 200 consenting symptomatic patients. Out of that, predominantly was male, accounting for 63.5%. And mean age of the patients was 93 years. Almost all admissions were deliberate self-harm attempts, and mean ingestion to admission time was 5.14 hours. Average number of seeds were taken by the patients for 3.66, and interestingly, 44.5% of patients have taken the seeds in crushed form, and 49.5% of patients have taken seeds a meal prior to ingestion of seeds. And regarding co-ingestions, 38.5% of patients has taken sugar and 26% of patients have taken alcohol as co-ingestions. High serum creatinine was recorded in 12% of patients, and high serum potassium was recorded in 33% of patients. First degree heart blocks was appeared after admission in 6% of patients, second degree AV blocks in 8% of patients, and complete heart blocks in 4% of patients. Bradycardia was recorded in 63.5% of patients, while reverse tick sign was appeared in ECGs in 12.5% patients within first 24 hours. The temporary cardiac pacing was done in 8% of patients, and 1.5% of patients, that means 3 patients, were died due to complete heart blocks after admission. We have calculated odds ratio to see whether there's any correlation between development of heart blocks and reverse tick sign of digoxin effect. Patients present with reverse tick sign of digoxin effect have higher odds of developing AV blocks within first 24 hours compared to those who were not presented, with odds ratio of 5.8. The relative risk of development heart blocks in patients present with reverse tick sign was 3.5. In conclusion, there's an association between development of atrioventricular blocks and reverse tick sign of digoxin effect, which is appearing in the ECG within first 24 hours in acute to early end of poisoning patients. And we recommend presence of reverse tick sign of digoxin effect can be considered as an early predictor of development of heart blocks, and therefore the patients might require facilities for temporary cardiac pacing and other interventions. So I would like to acknowledge Research Council of University of Sri Jawaharlal Sri Lanka, which is the funding source, and Teaching Hospital Batticaloa Eastern Province, and all the healthcare staffs and patients. Thank you.
Thank you. And now the paper is open for discussion.
So very nice presentation. We have taken all these patients from your tertiary center or secondary center?
Thank you very much for the question, madam. That was from a tertiary care center, which is teaching hospital in Eastern Province of Sri Lanka, where the OLI and ingestions, suicidal attempts are very much common.
All these having the facility for that reverse to temporary treatment, which you have mentioned.
Yes, at the moment in Sri Lanka, we are not using any antidote because the antidote is not that cost effective. I mean, the cost is very high, which is Digifab. So therefore, we are using, currently we are using some interventions like temporary cardiac pacing and other supportive treatments to manage.
Out of 200, how many patients needed that?
It was around 16 patients.
16,
Yeah,
one
yeah.
six.
1/6.
During your observation period?
Yes.
They required that?
Yeah.
Okay, thank you.
Thank you, madam.
this patient must be on other drugs as well.
This is actually a suicide,
Only
in the poisoning, yes, poisoning
right.
patients.
My question was like whether you have considered any other possible interaction with what the drugs they are taking. Or
Yes, we have taken their past medical history. So at this stage, most of the people are young patients, and they were not on any medications.
okay,
Yeah.
right, understand.
If they were on any medication which affect heart rate rhythm, we excluded them from the study.
Exactly.
Yeah. Yeah. One.
Actually, I am a nursing officer. When I was at Ampara Hospital, there were so many patients with Kaneru poisoning. There were no facilitated for pacing. At that time, we given already injection atropine. What about your idea regarding atropine injections? Regarding heart blocks and bradycardia?
Atropine is again a supportive treatment. Of course, that is true. These patients were managed conservatively for managing the bradycardia as well as for hyperkalemia, they develop hyperkalemia. So these type of management things are there. Definitive treatment is antidote. In the presence of, if the absence of antidote, so we are going for other interventions to manage their heart rate and the blood pressure and hyperkalemia. The other management will be gone. So that is atropine is appropriate.
Right. Thank you. Let's move on to the
Thank you, madam. Thank you.
oral presentation number 8. OP8, effectiveness of usage of intravenous lidocaine and intravenous ketamine infusions, combination for chronic pain in Pain Clinic, Colombo North Teaching Hospital, Ragama. Authors, Samanthi AAN, Ranasinghe SS, Methananda C. The presentation will be by Samanthi AAN.
Good morning to all of you. I'm Dr. Samanthi. Today my topic is effectiveness of intravenous lidocaine and intravenous ketamine combined infusion for chronic pain relief. I did this research during my MSc in clinical pharmacology and therapeutic course. We all know chronic pain is a common healthcare issue around the world and it is difficult to manage. Recently, there has been increasing interest in intravenous ketamine and intravenous lidocaine combined infusion for chronic pain management, not responding to other treatment modalities. Lidocaine and ketamine provide analgesia by activity on different molecular pathways, and administered together, they provide a synergistic effect. Well below the anesthetic dose of ketamine and well below the antiarrhythmic dose of lidocaine is used to avoid the side effects. Currently, this procedure is being done in Pain Clinic, NHSL, Ragama, Teaching Hospital, Karapeti, and Kandy Hospital in Sri Lanka. Here, the dose of 2% intravenous lidocaine, 5 mg per kg, and IV ketamine, 0.1 mg per kg, is given as a combined infusion over 4 hours of duration under the close supervision of an anesthetist. The patient is reviewed after about 1 month of duration and repeat the procedure if it is necessary according to the pain assessment. The studies regarding this intervention limited in Asian countries and has never been studied in Sri Lanka. My primary objective is to study the effectiveness of this intervention. Specific objectives to study the pain-free period after this intervention, to study the usefulness of this intervention for physical, psychological, and social improvement, to study the immediate adverse effects of ketamine and lidocaine with related to the doses used, and to study the patient satisfaction. A prospective cross-sectional study was done in Pain Clinic, Colombo North Teaching Hospital, Ragama. In relation to the research, any pain, either generalized or localized, lasting 3 to 6 months or more duration is considered as chronic pain without any interest of specific type of pain. All the consecutive eligible patients suffering from chronic pain registered for this intervention during a period of 6 months of duration is included. All the patients with contraindications for ketamine, all the patients with contraindications for lidocaine, any history of allergy to lidocaine or ketamine, and those who did not give the consent were excluded from the study. The duration of study was 6 months of duration. Ethical clearance obtained from the ERC committee PGIM. The permission also obtained from the head of the Department of Anesthesiology and Director, Ragam Hospital. An interview administered questionnaire was given. Pain assessment was done using the brief pain inventory short form. It's universally accepted pain assessment tool used worldwide. It contains several numerical scales. For the pain, it contains 3 numerical scales from 0 to 10. for the worst pain during previous 24 hours, least pain the patient experienced during previous 24 hours, then average pain the patient experienced during previous 24 hours. For the physical and psychosocial components, there are separate numerical scales for the general activity, mood, walking ability, sleep, enjoyment of life. The patients were given the explanation regarding the numerical scales, and I put the dot on the correct value after interviewing the patient. During the procedure, the patient was observed, and immediately after also, and later follow-up over the phone after 24 hours, after 2 weeks, and after 1 month. Physical and then reassessment of the pain done after 2 weeks, reassessment of the physical and psychosocial component after 1 month, patient satisfaction also assessed after 1 month of duration. During analysis, numerical values before and after were compared. The data were analyzed using statistical package for social sciences 23. All were 29 patients registered for the intervention. The mean age of the patient was 51.8 years. Back pain was the commonest presentation. Nearly half of the patient had chronic pain throughout the day. Among the intervention given before lidocaine ketamine injection, lidocaine alcohol injection, epidural injection, regional nerve blocks, fentanyl patch, sublingual ketamine, cognitive behavior therapy are the intervention given before that this intervention. For these interventions, 8 patients mentioned the rest relieve their pain, 4 mentioned oral analgesics provide pain relief, and nothing could relieve in 7 patients. Comparison of pain between and after the intervention, the mean value of rating of pain at it was before the intervention 7.48 has reduced to the mean value of 4.58 after the intervention, with the p-value of less than 0.05. The mean rating of pain at least prior to the treatment, 4.69, has significantly reduced after the intervention to a value of 3.07 with the p-value of less than 0.05. There was a significant reduction in rating of pain on an average when compared to the values before and after the treatment also. Prior to the treatment, it was 5.79 and 3.72 after the treatment with p-value of less than 0.05. Comparison of physical, social, and psychological scales, the mean value of how interfere with the relationships, how interfere with the sleep, how pain interfere with the enjoyment of life, then compared to the mean value of after with the values before the intervention, there's a significant reduction with all the values below less than 0.05. Patient satisfaction of the all patients, 22 mentioned it's a good intervention. As a percentage, 75.9. 4 people did not give a consent, comment, there's a percentage of 6.9. There was no improvement in 3 patients, as a percentage 6.9. Adverse effects of lidocaine ketamine infusion, 1 patient complained about sleepiness, other didn't give any complaint. As a percentage of sleepiness, 3.5%. Conclusion, intravenous lidocaine and ketamine combined infusion reduces chronic pain compared to current standard of care, relevant to reduce the intensity of pain, improve the physical activities, improve the mood, improve the sleep, and patients were satisfied also. But the study was done during 6 months of duration because the whole period given for that research was 1 year of duration. That need to be studied further, extending more time to recruit many more patients for the study because it is an effective intervention for chronic pain management. Thank you.
The plenary is open for questions and discussion.
Thank you. My question is like, when you have this combination, it's definitely prolong the elimination half-life and the area under the curve. So it's maybe like delaying the awakening of the patient. So how did you manage that because from the patient's point of view?
The procedure is done in the pain clinic under the close supervision of an anesthetist. Over the 4 hours of duration. After the intervention also, patient was kept in the pain clinic in the bed for further 2 hours of duration and closely observed until he or she is fully awake before discharge, sir.
So that, I mean, it hasn't given a negative one because the awakening is getting late because of the combination? Awakening of the patient because of the elimination half-life being prolonged.
Yes, sir.
Has it come as a negative kind of?
I didn't meet the patient is.
You only check on the pain?
Yes.
Sorry, nice work. What was the duration of infusion? Total?
4 hours of duration, madam.
Huh?
4 hours.
4 hours. Did you categorize the types of pain, chronic pain, whether it is because of...
Yes.
You didn't mention in your
Yes, in
presentation.
the questionnaire, I asked about which type of pain. Is it throbbing type, aching type, tearing type pain? Most of the patients complain about the aching type pain.
This chronic pain caused by some severe diseases or simple arthritis, diabetic pain,
Yes.
cancer pain.
Yes.
These are the certain conditions which causes chronic pain.
Yes.
So did you categorize, did you ask any history
Yes,
regarding?
madam. Yes, in the questionnaire, there was,
What was,
a separate
what was the
question.
cause of pain? Etiology,
Yes.
I mean. So, did you categorize or did you analyze which type of pain is relieved better with this intervention?
The commonest type of pain presented is lower back pain. The type of pain presented is aching type pain, madam.
You didn't get my question. I am saying that there is chronic pain caused by diabetic neuropathic pain, right?
Yes.
Cancer pain, that is a different type of pain than arthritic pain. All these have a different etiology and different types of pain, right? So which one was relieved better?
The back pain, lower back pain.
Okay, sorry. Okay, fine.
Thank you. Let's move to the next presentation. Frequency of... We have to maintain the time, please. Thank you. The next presentation is on frequency of pharmacogenomic variants affecting efficacy and safety of anti-cancer drugs among Sri Lankans, authored by Manchanayaka H.M., Ranasinghe P., Sirisena N.D., Vishnukantan T., Ariyature J.N., Tilakaratna S., Priyadarshini C.D.N., Handalage D.P.B., and Disanayaka V.H.W. The paper will be presented by Manchanayaka H.M.
A very good morning to you, distinguished chairpersons, judges, ladies and gentlemen. Thank you for this opportunity to present to you our study on the pharmacogenomics of anti-cancer medicines among a population of Sri Lankans. This is a brief outline of my presentation. I think we can all acknowledge the fact that cancer continues to be a leading cause of global morbidity and mortality. It is very much a problem here in Sri Lanka as it is in the rest of the world. One thing that we do tend to overlook is the morbidity burden that is posed by cancer chemotherapy-related toxicity. And this is despite the fact that these medicines continue to be the most widely used modalities of treatment for majority of cancers. Now, leaving aside the potential for medication harm due to medication errors, there is still room for toxicity even if the supposedly right drug is used at the supposedly right dose for patients of certain populations. Now, this is explained by the fact that there's a large inter-individual variation in terms of response, in terms of efficacy and safety of these medicines. And this is explained by the wide heterogeneity of genes that are involved in the pharmacodynamics and pharmacokinetics of these medicines. This cartoon shows how patients with the same diagnosis who are given the same prescription respond differently to the medicines. So on one end of the spectrum, patients respond to the medicines without any toxicity, and in the worst case scenario, there is no response with the incidence of toxicity. And it is this variation in response which has taken us away from the traditional one-size-fits-all approach to therapeutics to more tailor-made personalized therapies. Now, previous studies which have explored other classes of medicines have shown that the pharmacogenomic profile in Sri Lanka between our ethnic subgroups are largely similar and comparable to South Asian populations as well, but there were considerable differences in comparison to European and East Asian populations. And this is alarming considering that most of our dosing guidelines are adapted from Western countries. And it is for this reason that we wanted to explore the diversity of pharmacogenomic variants among our Sri Lankan population, which would pave way for personalized cancer therapies for our patients. Now, let me quickly take you through how we did this study. We started by looking for pharmacogenomically important genes in the PharmGKB database, which was supported by high levels of evidence. We then looked for variants, we looked for at the frequency of these variants among a population of 541 Sri Lankans who presented the Human Genetics Unit for whole exome sequencing for various clinical purposes. We then used their genotype frequencies to calculate minor allelic frequencies, and these were tested for the Hardy-Weinberg equilibrium. And then we compared our minor allelic frequencies with those of other populations, which were in turn obtained from the genome aggregation database, and comparisons were done using the chi-square test. So these were the variants which we identified. There is a variant of CYP2D6, which increases the efficacy of the drug, a variant of DPYD, which increases toxicity to fluoropyrimidines, a variant of NUDT15, which increases toxicity of thiopurines, a variant of XRCC1, which increases efficacy of platinum drugs, and a variant of EPAS1, which increases toxicity to sorafenib. So these cartoons illustrate the respective roles of these genes. So this brings me to my results. So as you can see, the sex distribution was more or less balanced, and the ethnic distribution was comparable to the rest of the country. And our minor allelic frequencies were consistent with the Hardy-Weinberg equilibrium. Now these calculated minor allelic frequencies on their own don't make a lot of sense unless we do comparisons with them. So the first round of comparisons were done among the ethnic subgroups within the country, and as expected, there were no significant differences for a majority of the genes, which is good because then the recommendations can be applied across the board in the country. But there were significant differences in the variant of XRCC1, which was found to be significantly higher among Tamils than among the Sinhalese. And this brings me to the crux of the present study, where we compared our minor allelic frequencies with those of other populations. And as you can see, there were significant differences in all of the variants. So for example, the variant of CYP2D6 was found to be significantly higher in the other populations, whereas the variants of DPYD were lower in the other populations. The variant of EPAS1 was higher among the Europeans, but lower among the other populations. The variant of NUDT15 was lower among the other populations, whereas the variant of XRCC1 was higher. Although we did look at compare a variety of other populations, we focused on the European MAFs, and that is because, as I mentioned, a majority of our dosing guidelines are adapted from studies done among Caucasians, and based on this, we postulated what the impact of this would be if dosing is continued according to standard guidelines, and therefore we postulated that there would be higher efficacy of tamoxifen because the variant that causes reduced efficacy is in fact lower among us Sri Lankans. Similarly, we postulated that there would be higher toxicity to fluoropyrimidines like capecitabine, fluorouracil, and tegafur, and higher toxicity to thiopurines like mercaptopurine, and in fact lower toxicity to sorafenib, and that there would be a lower efficacy to platinum-based drugs such as cisplatin, because the variant that is responsible for increased efficacy is in fact significantly lower among us Sri Lankans. This brings me to these recommendations. So based on our conclusions, considering the fact that there is a risk of lower toxicity among us Sri Lankans, it would make sense that we would require reduced doses of fluoropyrimidines. Similarly, we would require reduced doses of mercaptopurines as well in order to reduce toxic effects. And considering that the variant responsible for increased efficacy was lower in our population, we hypothesized that we would require increased doses of platinum compounds as well, because standard doses can lead to therapeutic failure. But as the slide mentions, these recommendations are highly tentative, and the only, the most important conclusion of our study is that the pharmacogenomic profile pertaining to cancer medicines is very distinct among us Sri Lankans, and as shown, it is distinct to most South Asians as well. And the most important recommendation is that we need more pharmacogenomic data in order to make more robust recommendations. And we have certainly laid the groundwork for that in terms of panel sequencing for larger, more representative populations. So thank you.
Thank you. Now the paper is open for discussion.
Thank you. That was very interesting. Now, based on what you found, would you be able to make some recommendations to the oncologists? Because particularly with regard to the drugs which can cause increased toxicity, do we have enough evidence for that?
So thank you for that, madam. It is true, this is not a nationally representative sample, but it remains that this is the largest sample that we have in this country. And this is actually a database of patients who have presented to the Human Genetics Unit for over a decade. And the reason for this small sample size is the fact that whole exome sequencing is a very expensive investigation. At present, it costs about 125,000 LKR. So this is quite a large sample size, and we have patients from around the country because the Human Genetics Unit is a reference center for genetics. So I suppose we can make certain recommendations, as you mentioned, with regards to the drugs that can cause very serious toxicity. But I would be very cautious in terms of these recommendations because these are not very robust. But certainly, I suppose clinicians can take into account some of these recommendations, especially, as you mentioned, when it comes to the toxic, especially toxic drugs, yes.
Mine is related with efficacy. We didn't categorize the subgroups. You mentioned in your recommendation, but during your methodology and during your results, you didn't mention which group have this variation in this genomic variation is common.
So, madam, as I mentioned, thank you, among the ethnic subgroups, there were similarities mostly, except for that one gene called XRCC1. And there were variations between us and the South Asians as well with regards to CYP2D6 responsible for tamoxifen metabolism, and one variant of DPYD, which is responsible for fluoropyrimidines. So,
no, my question, and I'm asking, when these drugs, anti-cancer drugs, are used for different types of, different categories of patients or types of cancers, they have a little bit efficacy issues. Some are more effective in particular cancers, but they are used as an combination therapy. So, for example, in breast cancer, we didn't mention paclitaxel and all that specifically, which is more commonly used nowadays. So, what are the genetic variations and what about their efficacy?
so that is a good question, madam. That is something we have yet to explore. We haven't.
I hope you will do it further.
Yes,
you expand your
yes.
study further to categorize the subgroups of the cancer and then see the genetic variations regarding efficacy and as well as safety, as madam asked.
Thank you for that recommendation, madam. We will take that into account.
Thank you. Let's
Thank
move
you.
on to oral presentation number 8. Assessment of awareness and safe practices of handling medicines by patients using selected medication safety indicators developed and validated for Sri Lanka. Authors Valiveta IP, Ranasinghe RAS, Samaranayaka NR, Jayawardena P, Galapathy P. Presented by Valivata IP.
Good morning, everybody. Our study is on assessment of awareness and safe practices of handling medicines by patient using selected medication safety indicators developed and validated for Sri Lanka. So, safe use of medicines by the patients is basically depend on the awareness level of the patients regarding his or her own medications, as well as kind of a medication safety practices they are following. So, according to the literature in Sri Lanka, only 54% to 96% of patients had adequate knowledge on their medications. So, our objective of our study is to assess whether medicines are handled safely by the patients using selected medication safety indicators which were previously developed and validated for use in Sri Lanka. We conducted a descriptive multicentric cross-sectional study. Actually, this was conducted as a part of island-wide study including 61 pharmacy settings, including 25 government hospitals, 11 private hospitals, and 25 community pharmacies, representing 25 districts in Sri Lanka. So any patient coming for the above settings with a valid prescription and at least one dispensed drugs was taken into the study population. Patients who coming for the private medical centers and involved patients and patients having only medical devices has been prescribed are excluded from the study. So 30 patients were selected from each of the 61 settings, resulting a sample of 1,830 patients were assessed for awareness and safe practices of handling medications. We use stratified random sampling techniques when we are selecting the pharmacies, and we use systematic sampling technique when we selecting the patients. An interviewer administered questionnaire was used for the data collection. Data collection was basically done by the principal investigator and 8 data collectors. Data were analyzed using SPSS software by the principal investigator. So these are some of the important aspects where we got as our results. We observed that less than 4% of the patients had the awareness of the names of their medicines they received in all 3 type of settings. So further, we investigated the percentage of patients aware the indications of the aware about the indication of all the medicines they received. That also indicated somewhat below, which is indicating maximum 30% of the patient who coming for the private hospitals. So then we assessed about the storage practices followed by the patients. So percentage of patients who indicated that they were store medicines at home in a separate containers with recommended labeling was also lower, indicating only 15% in the patients who coming for the private hospitals, and those patients coming for the public hospitals and community pharmacies were much below percentage observed. Only around 10% of the people indicated that their medication was stored at home in a locked and a separated area, which is indicated an important safety issue. So even though we observed many of the awareness lapses and also some kind of incorrect practices of handling medications, only little percentage of patients admitted at least they had erroneous administration of medicines within a stipulated time period. But they admitted they are on self-administering antibiotics on their illnesses. Conclusion of our study included that majority of the patients were not aware of the name and indication of their medications, and storage practices of medications at home needed improvement. A few patients only admitted that they're taking medications erroneously. They have very low awareness on medications. Patient education is a critical factor that need to be addressed to ensure the medication safety. Finally, I would like to acknowledge university research grants, University of Sri Jayawardena, for facilitating our study funding sources. Thank you very much for listening.
Right. Time for questions and discussion.
Thank you very much. That was very interesting. I have 2 questions. Now, you were saying that that the patients did not label the containers the way that they are expected to label, and that you expect them to be kept in a locked, separate area. How did you define those criteria? On what basis, taking into consideration the type of patients and their living conditions in this country?
Actually, madam, thank you for the question. We can't expect the perfect storage conditions and perfect labeling and related things according with the resources they have. But still, when we focusing about the medication safety related aspects, we should have proper labeling. At least they won't mixed up with their medications with their own other medications, as well as the medications with using other family members. So some majority of the patients were taking the in hospitals they given with the paper packets. They keep, most of them just put it into their bags and bringing it to the home, which is not actually recommended practice. But then after, when we exploring more about their interview, they were just keeping it at home, whether there may be a risk of occurring some quality related problems with improper storage. So we asked, how do you store your medications? Some of them were directly put it into separate containers at the hospital itself. But they won't have, most of them won't have proper labeling on it. So most of times they are clinic patients coming for a longer period for their clinics, and they have that, they tell that they have memory. I know how to take this medication, therefore I won't label. They are not concerning about the safety practices and unintentional errors they may go with.
Right, no, that was not exactly my question. My question was, how did you determine, on what basis did you come up with these criteria, considering the population? Then the second thing is, you said that you expect them to label. What do you want them to have in that label? The patients, we are talking about patients, no? So how would they label the bottle? With the name of the medicine, if you want to put them into separate containers, is that what you are expecting as a criterion?
Yes, at least that separate labeling, or at least pasting the label on their container, that there's original label dispensed by the pharmacist.
Okay.
They can at least paste it in their container. That's what we are expecting.
The sample population,
Yeah.
was it a mix, this random selections?
Random selection.
You didn't check on any socio-economical factor, like any group?
No, not like that. Only that we took a representing sample from all the districts in Sri Lanka. That's all. We were not focusing on the ethnic or any other factors.
So all like Sinhala speaking crowd, or?
No. There were representation, but in the sample selection we didn't focus in numbers, but there was a mixture of Sinhala and Tamil speaking people majority, because we conducted it in Northern province and all the other provinces covering as well.
Okay, thank you.
Nice presentation. But as Madam said, the criteria you mentioned for assessment is little bit not possible. Patient can't keep or himself or herself put a label. Usually the instructions are on all the medicine is keep out of reach of the children. That is a major, we can't keep it all the time in the lock and key and for the safety purposes. Second thing, in your results you mentioned that repetition of or self-medication by antibiotics given through representative. The percentage was very less. It is very common to use the same medicine, repeat the medicine once they have taken earlier. So it is a very common practice, especially in South Asian countries. They used to take medication without prescription, or whatever they have taken for earlier disease, they will repeat the same. Right? Even for other patients, they recommend, I have improved by this particular medication, so we also take that particular medication. So that is very common practice But your result shows it's only 3%, I think, very less percentage is
Yes,
there.
madam. Actually, that may be a limitation of our study because we also studied in previous studies that there were some higher percentages. But in the case of our study, we didn't. This was not an observational study. This was interview administered questionnaire we asked directly from the patient. But even though they are taking, they may not admit it. I
Okay.
think that is the point there. And the lock and key related storage thing, actually not only the lock and key, we ask how do you, as an open-ended question, how do you store your medication, and whether it is in a separate area or under the lock and key. Most of them, their answer for the open-ended question was on the table or something like that. Then we categorized it whether it is appropriate or not.
Okay, thank you.
Thank you very much. Let's move
Thank
to the
you.
next presentation. Assessment of medication safety during the stages in medication management in Sri Lanka using developed and validated selected medication safety indicators. Authored by Valivatta IP, Samranayaka NR, Javadana P and Galapati P. Paper will be presented by Valivatta IP.
Thank you. Our next study is on assessment of medication safety during the stages of medication management in Sri Lanka using developed and validated selected medication safety indicators. So, medication management, in the sense, we focused on three main aspects of regulation, procurement, and storage and distribution. So, safety concerns in regulation is important to avoid circulating substandard or counterfeit medications in the country and to ensure the safety, efficacy, and quality of the medicines available for the community. So, in the procurement, safety concerns are important to make available or to purchase the medicinal products complying with the regulatory requirements. And the storage and distribution, it is important to minimize the influence of environmental factors for the quality of, to determine the quality of medicines. The objective of our study is to assess medication safety during regulation, storing and distribution of medicines in Sri Lanka using selected content validated indicators. We conducted a descriptive multicentric cross-sectional study to assess the safety indicators related to regulations. We conduct our study in National Medicines Regulatory Authority and also 11 private hospitals, 25 community pharmacies representing all 25 districts. To assess the storage and distribution practices, we conducted our study in relevant to central stores under the authorization of Medical Supplies Division and central medicine stores in public hospitals representing 25 districts in Sri Lanka. And also we focused on sub-stores of 61 clinic pharmacies including government, private and community pharmacies in 25 districts. This is the study population we studied, and we had calculated the sampling size. We got kind of a convenience sampling to the assessment of regulation in focusing on private and community pharmacies. When we assessing the storage and distribution related indicators, we got all the medical stores authorized under Medical Supplies Division and some storage facilities under the public hospitals. And also we studied stores located in pharmacy settings in public sector hospitals, private sector hospitals and community pharmacies using stratified random sampling. we used three types of study instruments to assess a separate checklist on safety to assess the safety in regulations, the safety in central storage and distribution of medicines, and the safety of storing medicines in pharmacy substores. So, as a part of an island-wide study discussed in previous presentation, data were collected by principal investigator with the help of 8 data collectors. So, we collected some information about the availability of medicines with their brand names in community and private sector pharmacies, and also we get some information about internal databases from NMRA about quality failed medicines and adverse drug reactions reported. So, when we are studying about storage and distribution practices, both the central stores and stores of pharmacy settings were checked for the compliance for the recommended storage conditions, proper separation of medicines, availability of facilities for medication storage, and records maintained on call storage. The difference between the main storage and the pharmacy storage was we used separate indicators for pharmacy settings regarding the ensuring safety of storage of look-alike, sound-alike medicines and high-alert medicines in pharmacy settings, which are not much applicable in main storage complexes. So let's move into the results we obtained. We got 80% of the pharmacies without the registration of pharmacy according to NMRA, and 24% of the community pharmacies we observed only had the physical presence of a registered pharmacist. The percentage of unregistered medicines we observed were 1%, and percentage of essential medicines with only one registered supplier was 5.5%, and percentage of essential medicines registered with more than 20 suppliers was around 16%. These are some structural indicators we focused on the regulations. These are some indicators we focused on ADR and quality failed medicines. When we considering about storage facilities, most of the things are very well adhered to the storage guidelines, but we observed there are lapses in temperature monitoring of cold storage in public sector hospitals, pharmacies and community pharmacies. And also there was a lapse in temperature monitoring in pharmacy settings also. So strict monitoring is needed for unregistered medicines and storage of LASA medicines and high alert medicines, temperature monitoring and monitoring cold storage during transportation. Thank you very much.
Thank you. Now the paper is open for discussion.
I know this question is not under the scope of your study, but for my curiosity, like, is there any particular reason why you didn't choose the drug disposal of drugs in Sri Lanka? Because it's one of the burden, like, for the country. Disposal of drugs. Any particular reason why you didn't choose that?
Actually, yes. According to my background, that I think there is not still well defined disposal procedure is available in Sri Lanka.
There's a big guideline,
but it's not in practice. So we were focusing on basically government hospitals and private and community pharmacies. So as there was not guidelines to assess as indicators, we didn't actually focus in this study, but it should be assessed definitely
Yes,
in
maybe in
future studies.
Yeah, thank you.
Yes.
Thank you for your nice presentation. I have one question. You had looked for the storage conditions, RMSDs and private pharmacies as well. So are there any guidelines? What sort of guidelines and the factors you looked into? Any guidelines particular?
Yes, actually, when we considering about hall storage in RMSD and hospital storage, we developed separate set of guidelines. Most of them are based on good storage practices published by NMRA. Those are the things we assessed in RMSD and hospitals.
Okay, one more question. Were you looked into the essential medicines, or were there a list of medicines that you looked at?
Actually, we referred the available list of medicines published by NMRA, internal document, the brands registered on the date of December 30th, 2023.
Okay, thank you.
So nice presentations and a nice observational study, and definitely the storage affects the efficacy as well as safety of the patients, and that definitely improve the safety of the patient. Storage is also important. So the good, nice study. Thank you.
Thank you very much.
Right, thank you.
Thank you, madam.
Let's move on to the final oral presentation. Availability and composition of herbal products with beneficial health claims for chronic non-communicable diseases in Sri Lanka. Authors Veerakon WADJC, Mana Perumayu, Ranasinghe P. Presented by Veerakon WADJC. Over to you.
Good morning, ladies and gentlemen. I'm Utpali Mana Peruma. I will be presenting today our study on the availability and composition of herbal products with beneficial health claims for chronic non-communicable diseases in Sri Lanka. When plant-based products are used to treat diseases or to maintain health, they are called generally herbal products. These are widely available in the market, and there is an acceptance for these products because they are perceived to be safe and offer lower cost. There is concerns regarding the quality control and the quality assurance of these products, especially in our parts of the world, and there is a lack of stringent guidelines and monitoring of these products as well. The objectives of our study was to determine the composition, therapeutic claims, and identified herbal products marketed with beneficial claims for chronic non-communicable diseases, and to assess the availability and affordability of these products in 2 districts of the western province of Sri Lanka. I move on to methodology. So we selected medicines that had a label claim directly or indirectly as beneficial for chronic non-communicable diseases, and the products had to have more than 60% of ingredients of herbal origin. We excluded products which needed an Ayurvedic practitioner's prescription, or if they had a Western medicine in it. We developed a data collection tool where we recorded all the necessary data about the products that we surveyed, and we accessed supermarkets, pharmacies, and specialist Ayurveda stores to gather data in Colombo and Kalutara districts. We determined the availability and affordability of the medicines based on the guidelines given by the World Health Organization and Health Action International. For affordability, we calculated the cost of 30 days taking of the herbal product based on the salary of the lowest paid government worker in Sri Lanka. So what we found was that many products could be accessed if you went to either a supermarket or a pharmacy, and we found a total of 88 products in the market. Many of the products came as tea bags, followed by capsules, and tablets. The most available product was a tablet form, followed by a syrup, and there were many tea products, as I mentioned before. Many of the products had 3 to 5 ingredients in them, but the number of ingredients ranged from 1 to more than 10. The commonest ingredient was tea, followed by Indian gooseberry. So when we looked at the labels, the vernacular names were there in about half of the products, along with the scientific names. Only the scientific nomenclature was seen in 7 products, and we found errors in a few in the scientific names. There were duplication of the scientific names and the vernacular names in the list, and the specific part that was in the product could not be identified in many. There were few non-plant-based ingredients also mentioned, and none of the locally manufactured products had the total composition given in their label. The direct claim of benefit was mainly for diabetes, and the indirect claim was to enhance the immune system. When we looked at the range of claims that were there in the products, they were for all the systems of the body. There were many claims, and the other claims like 100% natural, 100% organic was also found in many of the labels. And it's noteworthy to see that some claim that there are no risks of drug interactions, and they were an ancient Ayurvedic formula. Many of the labels did not mention any side effects, and 4 mentioned that there are no side effects coming from this product. Only 5 products mentioned any type of side effect when using the products. The direct indications were mentioned in few, diabetes being the commonest, and a few products did mention contraindications, pregnancy being the highest percentage. When we looked at the registration status mentioned in the labels, many of the products did have the Ayurveda Authority registration number mentioned, but when the products were imported products, they did not have this in their label. A manufacturer registration number was mentioned in some of the products, and it's noteworthy to see that we observed that 2 locally manufactured products had the same manufacturer had the identical registration number. So when we calculated the affordability was more than a day's wage of a government worker, and the maximum days of wage was 6. So with the large number of products, without proper information in them, and the composition not clear, it may confuse the consumers, and they may feel again with the claims that there are no adverse effects of the products because of the natural origin as well. But there is large number of evidence that there are drug interactions or cautions when you are using more than what is required, or due to adulteration of products, some toxic side effects as well. So the lack of strict monitoring is evident, and the direct claims that are given in this product may delay treatment by patients, or adherence issues may occur. And these scientific claims are not scientifically justified also. There is a lot of evidence that these products are adulterated. Although I did not present today, we did find some of the products were adulterated with colors and bulking agents. So we recommend strict regulations, pharmacovigilance, strengthening of the regulatory mechanisms, and improvement of consumer awareness. In conclusion, the availability of herbal medicine preparations for chronic NCDs was high, and the affordability was not acceptable, and the misleading and lack of information is of a concern. I acknowledge all who helped in the study, and thank you for your attention.
Forum open for discussion.
Thank you, Utpali. That was interesting. Just a question. You said the local products, in the local products that you looked at, all the ingredients were not in the label. So how did you make that conclusion?
Because say, if it was a tea product, of course it would contain tea bags, but for some things like the tablets, the excipients are there. For the syrups, there may be other ingredients as well. And it will just say, let's say, Goraka, or the vernacular name is there, but nothing else was mentioned. So,
Is that a requirement for their products as well? Do we have any guidelines for the Ayurveda products as to what the requirements are that should be in the label?
there is, I think, no strict regulation to say all the ingredients should be available. And these were just direct-to-consumer products also. So maybe that's the reason.
In continuation, also nice presentation. In continuation, that there are so many excipients they have added. Some are mentioned, some are not mentioned. That also affects. One more question. You mentioned affordability. What does it mean with this particular presentation?
We adopted the usual WHO high criteria. So the recommendation is to get the number of products that one uses or consumes within a month, and then divide the cost of that with the the daily wage of a government worker who's paid the lowest salary. So if one day's salary is more
I
than,
don't think that is the right thing or
Yes,
right way
it's-
to calculate the affordability as per cost of the medication, because we didn't compare with the other medications on that. So it's not, I don't think it is relevant with this study.
I agree, madam. And
okay,
then
okay,
people
thank you.
would be using this as an additional thing, not because they really want it. So they may be willing to spend that money as well.
So that if that is added or in addition with the all other medicine,
yes.
alternative medicine, this can be different. But we didn't mention in that. But I don't think it is relevant with this particular study. Okay, thank you.
Thank you, madam. Thank you for the comment.
Right, thank you. In the interest of time, let's conclude today's oral presentation session. I would like to thank the judges, my co-chair, and the presenters. Thank you.
Thank you for a great session. Your research advancements are invaluable for enhancing our practices. Next, we move on to Plenary 2, chaired by Professor Rohini Fernanda Pulle, Senior Professor of Pharmacology, Katalavada Defense University, and Professor Pridarshini Galapatti, President of SLACPT and Senior Professor of Pharmacology at the University of Colombo. The topic of the session is ensuring medication safety in clinical trials. Thank you.
Good morning to all of you. So in this session, we are going to listen to a very interesting talk by Professor Asita De Silva. Many of you know Professor Asita De Silva. He is a clinical pharmacologist, senior professor of pharmacology at the Faculty of Medicine, University of Kelaniya. And he had his clinical pharmacology training in Oxford with a PhD from University of Oxford. And currently he is conducting many multi-center clinical trials in Sri Lanka on many diseases. So I think he has set the stage for conduct of clinical trials in the country. He is an accomplished researcher. He has published widely, and I think he was in one of the, he was among the 2% scientists in the 2% of scientists in the world last year. So over to you, Asita, to do your presentation on patient safety in clinical trials. Thank you. Over to you.
Do you have a pointer? Oh, okay. Good morning, ladies and gentlemen. As you heard, my name is Asita, and I'm a clinical pharmacologist and a trialist by training. And I work in the Faculty of Medicine in the University of Calgary. I've been there for 31 years, and I head the trials unit in that institution. Before I start, I have a couple of disclosures, which it's mandatory for me to give to you. I'm a member of a number of international steering committees on these ongoing studies on stroke, atrial fibrillation, intracranial hemorrhage, and of course hypertension. I currently have grants from these institutions, MRC, DFID, and Wellcome Trust in the UK, and the National Health Medicine Research Council from Australia. Having said that, my disclosures out of the way, we all know that appropriate clinical decision making requires good information, robust evidence on the benefits and risks of the therapeutic interventions that we use on our patients. Decisions made without reliable evidence, either because these studies have not been conducted or they've been conducted badly, can cause serious harm. We also know that the best quality of evidence comes from properly randomized controlled trials, level 1, better than any other research methodology in terms of quality of evidence. But trials are difficult to do. They're prospective and they're objective. They take a long time, especially if you're a researcher in cardiovascular disease. Outcomes are very hard, usually death we deal with. But it's an old science. If you look at the literature, the first reference to a clinical trial goes back to the time of King Nebuchadnezzar of Babylonian times, where there was a trial that was conducted, which some people believe was on meningitis. But there were clearly two different groups, two different interventions those days. But the modern trial, the first modern trial, incorporating the current methodologies that we use, blinding, randomization, and so on, using controls, he's attributed this trial, MRC-funded clinical trial on tuberculosis, streptomycin tuberculosis, by Bradford Hill and his colleagues in London. Since then, over the last 50, 60 years, the US FDA estimates that about more than 1,000 novel therapies have been introduced to us for the benefit of mankind through good clinical trials, good clinical research, ranging from beta blockers right down to today's blockbuster drug, semaglutide. And of course, your anti-cancer vaccines and so on, everything in between. Now, we also know that if you look at the life expectancy increase over the last 40 years, human beings live 10 years longer on average, and 6 of those years are attributed directly to good clinical research. However, clinical trials are conducted to address a doubt. You don't do trials if there's no doubt. We do clinical trials based on the principle of uncertainty. And as a result, it's research. It's another research study. We use, in clinical trials, the human participants as experimental tools. As a result, however small, especially if you're looking at a new therapeutic intervention, there's a risk of toxicity, however small. And more importantly, from my point of view, I always keep this in mind, the information that the trial generates, the data, may not be, most times, of direct benefit to the trial participant. These two are very important principles that we have to keep in mind. And as a result, the patient's safety, the participant's safety, in research that we indulge, we get involved in, especially clinical research, is very important. It's non-negotiable. So how do we do that? On the one hand, we need robust evidence. On the other, we need to do these studies enshrining or based on the principle of uncertainty, but at the same time, make sure patient safety is well looked after. That's why trials have to be properly designed and properly conducted and go through all the hoops that we know. And we'll never have this situation where we have a brand new idea which has been previously thoroughly tested. It doesn't happen, it doesn't exist. But we also know that through man's various acts of omission and commission, history is replete with various disasters and tragedies. The Nuremberg trial, if you remember, the Nazi war crimes, experimenting on unwilling war prisoners or just normal human beings, the thalidomide disaster, the sulfarinimide disaster, Tuskegee tragedy, over the last 70 years. And these events led to the realization that there is a need for clear rules and regulations to control, guide, regulate medical experimentations to improve patient safety, primarily patient safety in clinical research. So if you look at this journey in one snapshot, which we have moved towards good clinical practice, ICH GCP today, which we talk about so eloquently, and we are all disciples of that. We have moved from various tragedies, as I mentioned, over the last 60, 70 years, and various committees have been established, various codes established, and reports generated. The Belmont Report, the Nuremberg Code, the National Research Act of 1979, and so on and so forth. But as a result, ultimately ending up with ICH GCP based on the Declaration of Helsinki, very important aspects of research involving humans are today, we probably take this for granted because this is standard practice for us, but taking written informed consent, making sure appropriately qualified medical personnel conduct trials. For example, in my opinion, obstetrician should not be a principal investigator in a heart failure trial. Assessing the benefits and risks very clearly and making sure they're addressed in a very good protocol, the so-called clinical equipoise. Where possible, prior animal experimentation, at least to establish safety of an intervention that we are trying to test in a clinical trial, and making sure we understand vulnerable populations and the safeguards required. Drug safety and efficacy, developed through different phases. New interventions do not go straight into efficacy trials. We know there are phases 1, 2, and 3. I'm not going to go into that today. Development of therapeutic intervention through very, very careful phases, highly regulated. Approvals from various committees, IRBs, ethics review committees, which include lay people. The composition is clearly defined. Respect for participants and beneficents. All these important principles came about not overnight, but over decades through the mistakes and the trials and tribulations that we have gone through. And today, if you look at GCP, I'm not going to give a talk on GCP because that's not the idea here. It has two principles that are very important for a clinical trialist. The first is to protect the rights and welfare of the participant, and the second, to ensure the quality and integrity of data. Because trials generate evidence. For example, trials on NCDs are usually large. The hypertension trials we do have thousands of patients. However, the evidence that has been generated from, let's say, 10,000 people, 20,000 people, for example, COVID vaccine, are given to millions. So the data quality and the integrity is again non-negotiable because they have to be generalizable to populations. And overall, there are 13 main points in good clinical practice guidelines. And if you look at 3, which I've highlighted in red, includes a trial should be initiated or continued only if the benefits and risks have been looked at, clinical equipoise, the rights and safety of the well-being, the safety of the participant taken care of and addressed, and of course, freely given informed consent. Now, all these have been built in to bring about safety, to ensure safety of clinical trial participants. And GCP demands these from all these stakeholders involved in a clinical trial, starting from patients, sponsors, investigators, scientific committees, regulatory bodies, and so on. Regulators and ethics committees being the independent groups in this stakeholder group. Now, all these individually and collectively bear responsibility to ensure patient safety. The sponsors, for example, are expected to develop the investigational product through the correct procedures, prior animal testing, different phases, submit volumes of information, tons of data to regulatory bodies and get approval to move to the next phase and so on. Select the investigators who are appropriately qualified. Make sure the investigators understand the protocol on the part of the investigators. They have to know the protocol. They have to look after the patient. Clinical care is more important than the research, and those responsibilities, managing the investigational product, if it's a product that has to go through a cold chain, so be it. All those responsibilities. The scientific steering committee, usually large trials have trial steering committees of experts that guide the trial, and they're informed by what a lot of people may not know or ignore, data safety monitoring committees. These large trials that we are involved in, we are blinded. We are blinded as investigators. And the intervention is concealed from, it's double blind, either patients and us. But can everybody be blind? No. That's why data safety monitoring bodies, data safety monitoring committees of experts, statisticians, who are independent of the study are established. And they periodically review the information. And visually, we produce a charter for the DSMB before we start a trial, which tells at which point the DSMB will review the data. For example, it can be either time-dependent, every 6 months, or the number of patients randomized, every 500 patients or 200 patients, depending on the numbers you're looking at. And they get unblinded data. And they look at very critically. And they advise the steering committees and say, it's safe to continue, or it's futile to continue, or just box on. And of course, the regulators, the ethics review committees, regulatory bodies, they need to understand scientific principles. It's not easy sometimes. Ethics committees have lay people. That's a balance to ask the correct questions. But there's a requirement on their part, in the interest of research, in the interest of science, for them also to be very conversant in the science, to understand the principle of uncertainty, to understand the value of the question that is being addressed, and to be able to tease out the different aspects in the protocol that have been introduced to minimize risk and to improve patient safety in clinical trials. So, if you want to do, for example, a clinical trial in Sri Lanka, it's legislated, it's a law today. Clinical trial regulations of 2019 under the NMRA Act of 2015 mandate that we need approval from the regulator recognized ethics review committee, regulatory clearance on the regulator itself. There are expert committees established there. Some of you are members of that. Registration in a clinical trial platform. We prefer the Sri Lankan one, which is part of the WHO. That is a public scrutiny. And of course, clearance from the head of an institution. These are minimum requirements. And when a protocol and an application for clinical trials go through these, the responsibilities I mentioned earlier, the stakeholders, which are clearly defined, matter. And they come into play. And when we go through this, we believe that a good scientific research question is about to be addressed through a good, sound, robust protocol. So what entails? So that's mandatory. I'm a trialist, I have to go through this. That's the law. But from a point of view of a researcher, keeping in mind the importance of a question that we are trying to address, keeping in mind the importance of patient safety, in my opinion, there are a few criteria for a good clinical trial. First is you've got to address an important, clinically relevant question. And when I was training, I was always told that it's important to address and find a solution or try to find a solution to a moderate healthcare problem. So a small, moderate impact on a large healthcare problem is far more important than a large impact on a very minor healthcare problem, the example being midlife male baldness. No offense to anyone in the audience. And we have to answer it reliably. We have to answer it reliably because, as I said, we generalize these results to populations. Random errors, in comparison to the effect that we study, the noise, we call them noise, need to be taken care of. And that can only be done through adequately powering a trial. That is the number of people, the number of participants in a trial. If you don't power a trial adequately, if the number of participants are not enough, you will never get a proper answer. Avoid or minimize bias through various mechanisms, randomization, blinding, controls, and so on, beyond the scope of this talk. And of course, look at the risk-benefit. Clinical equipoise, address risk-benefit, participant safety. This, to me, would be important irrespective of the regulatory requirements, irrespective of the mandated requirements that have been brought on us, which we are part of. This is what is important from a trialist point of view. This is what I would like to focus today. As researchers, as clinical pharmacologists, as trialists getting involved in this kind of work, the protocol, the research study that we undertake must clearly address at least these. And modern clinical trials, in comparison to Bradford Hill's 1948 streptomycin tuberculosis trial, are very different. They're qualitatively different. It has changed, not so much because of regulations, but they've changed qualitatively because we know that early trials of antibiotics like streptomycin, they involve small number of patients and they produce large effects. So you can get away with a small number of participants. The effect is very big, it's very clear. Pneumonia is cured, tuberculosis taken care of, fantastic. But today it's different. If you especially look at NCDs, most treatment effects at best would give you a moderate benefit, moderate effect. You're not going to get large impact. For example, if there is an intervention in the world that can reduce the incidence of myocardial infarction by 1%, you might say, what's 1%? But if you take the scale of the problem, that's a massive impact. So we're looking at that moderate effect size, and to detect such moderate effect sizes, because of the existing very effective treatments, we need large numbers. We need to detect a difference, to detect an effect. And of course, as a result, multiple centers are involved across the globe. But in addition to that scientific requirement, there are now lots of countries that sign into diversity. I know Canada has done that, I know UK has done that, where diverse populations have to be included in studies if funded from institutions in those countries. The requirement for minorities, requirements for marginalized societies, different ethnic groups, and so on. So it's complex, it's complicated, and the modern trial is not easy to conduct and design. And I'm a great believer of these 4 trials. The ISIS one, International Studies of Infarct Survival, 1 to 4. I had the benefit and the privilege of being trained by Richard Peto. He told me recently that, Asita, after the ISIS trials and the heart protection study, it's all been downhill. It's just joking, of course, but that's the value of these 4 large studies. If I take ISIS 2, which some of you remember from time to time because I bring this up all the time, the use of aspirin, streptokinase together after myocardial infarction, and the benefit was very clear. You can see if this is weeks after starting treatment, and that's the percentage dead, those who, not survival, dead. So you can see that some weeks after treatment started, if it's a standard care at that time, this is the number of people who had died. And that's aspirin alone, the intervention, the effect was pretty obvious. Streptokinase alone reduced death from very early time. The difference, the curves, the graphs separated very early, and they kept widening as it went along. And when you give both these together, streptokinase and aspirin, the benefit was even greater than the two individual treatments. That was ISIS-2, and it showed that streptokinase reduced death, risk of death, over a month by more than 20%, so 20% survival. The factorial design of this trial provided such benefit, and they showed that together they reduced relative risk of death by about 40 to 50% during the hospital stage of this patient, the acute stage. The benefit of streptokinase was greatest when given early, but the benefit continued, and that was the value of a pragmatic trial without any restrictive criteria, and provided clear evidence for the value of aspirin. And it changed clinical practice. And today, this is standard. Priyadashri's husband would, closing his eyes, start doing all this. But that came through hardcore research, and this protocol was based, this is why I bring this up all the time, on the principle of uncertainty. The eligibility for ISIS-2 was, in the eyes of lay people, non-clinical trial is complicated. It said that if the responsible doctor, the investigator in this trial, is reasonably certain that the trial treatment, either streptokinase, infusion, or aspirin, clearly indicated or clearly contraindicated, that patient was not eligible. So here's a patient, in your mind, you think streptokinase is indicated, or patient B, streptokinase not indicated, contraindicated clearly. But anyone in between, where you don't know, it's neither contraindicated nor clearly indicated, the uncertainty principle, those patients were eligible to be randomized to this trial. And the result was staggering. But that safety feature was built in to ensure patient safety, which is the title of my talk today in the trial. Anyone who was clearly indicated or clearly contraindicated were not taken for the trial. So the benefit was there. Of course, there's a risk, but the benefit outweighed the risk. And this is another example that I give from something that's ongoing right now. These trials we are doing for US FDA submission. This is not new medicine. These are 3 existing medicines that we've been working on since 2018, trying to improve levels of control achieved for patients with high blood pressure. Our approach has been to use 3 antihypertensives in quarter dose, quarter strength, half strength, or full strength in a single pill given as initial treatment. I'm not here to talk about the protocol. I'm not here to talk about the trial. But this study, because of US FDA requirement, they demanded, there was a period of placebo control. They said, these 3 medicines together in a single pill, you have a lot of data to show benefit. These 3 medicines, telmisartan, amlodipine, endopamide, they've been here for ages. But we need a placebo control to properly define the adverse events profile of this single pill. So there was a requirement for a period of this trial, just 6 weeks, for placebo. Placebo control to an arm, in an arm of patients who are hypertensive. So how do we take care of this patient group safety? How do we minimize risk? It's an important question, but this is mandated. The first was to include patients with mild hypertension. Patients with mild hypertension, all the current guidelines say that up to 4 to 6 weeks, they need not be or should not be started on pharmacological treatment. So select patients with minimal risk. We excluded patients with eGFR of less than 60. Any moderate advanced renal disease were excluded. Only included patients who had very low cardiovascular risk. We use Q risk, less than 10%. If you go, you can play with it. It's available online. You do your Q risk. If you put male, over 50, those are the questions they ask. Family history of heart disease, that's enough. Your Q risk is more than 10. If you put diabetes, smoking, hypertensive, well, Q risk goes through the roof. Those patients we did not randomize. So the Q risk had to be less than 10. Q risk simply means if you take 100 people with a risk of, let's say 10, 10 of those people, that's 10% of those people, will have a heart attack over the next 5 years. So if Q risk is 50, and that's my profile, my Q risk is 50, well, if you take 100 like me, 50 of them will have a heart attack over the next 5 years. So very low risk patients. Daily home monitoring, we had devices that the patients were given. It was Bluetooth enabled. We did not only rely on clinic blood pressure, we used home blood pressure, where at a particular time, the patient puts the cuff on, and immediately to a central place, the blood pressure is transmitted. Which brings me to an important point in a clinical trial. There are lots of responsibilities on the patient or the participant himself or herself to ensure safety. Compliance to the protocol, adhering to the requirements that we have made very clear at the time of consenting, adherence to the prescription, coming for clinic visits, because we know patients who participate in clinical trials, they're so well taken care of. They get rite of passage everywhere, do better than those who are not in clinical trials. But in order to do that, we had home blood pressure here, daily telemonitoring, and of course, the overarching principle of investigator judgment. In the opinion of the principal investigator, in the opinion of the clinician, he could change. He could take patients in or out, no discussion. That's the value of pragmatic trials. We have concluded these results are exciting. We are going to present it in London in August at the European Cardiology Congress, and of course, publish it sometime soon, and submit it. We already submitted to the US FDA for approval. So finally, ladies and gentlemen, what I tried to say over the last 20 minutes was to clearly, what I wanted to say was, robust evidence from well-designed trials, the cornerstone of therapeutic advancement. Safety of trial participants in any research is sacrosanct, non-negotiable. And in addition, outside the requirements of regulatory and ethics regulations that are mandated on us, I believe that trial protocols, good research protocols, must incorporate very important, very clear risk mitigation strategies to ensure patient safety is enshrined, and clear understanding of the protocol. The study that we are undertaking, both for investigators as well as regulators and ethics committees, is challenging but very important. And finally, ensuring patient safety is collective responsibility. It's not just one, all involved, from patients to the investigators. It's a responsibility that has to be undertaken. And that's not, again, as I said, not negotiable. Thank you very much.
Thank you, Asita, for that very informative and very clearly delivered lecture, and I'm sure all the participants would have learned a lot on safety of clinical trials. Now I call upon you to come to receive your certificate for delivering this lecture.
Thank you. Following that enlightening plenary, we now begin Symposium 2, chaired by Professor Chandani Vanikatunge, Senior Professor of Pharmacology, University of Sri Jardhanapura, and Dr. Tilanka Senaviratna, Senior Lecturer in Pharmacology, University of Peradeniya. This symposium will cover key actions areas for medication safety.
Good morning, everyone, and welcome to the second symposium of Clinpharm 2024. I'm Chandani Wanikatunga, and my co-chair is Dr. Tilanka Senaviratna. The symposium will discuss different aspects of the key action areas for medication safety. Okay, right, thanks. Without much ado, I'll ask my co-chair to introduce the first speaker. There'll be a slight change in the program, and Professor Nithushi Samaranayaka will start the symposium, and Dr. Tilanka will introduce Nithushi to you.
Yes, so it's my privilege to introduce the second speaker, for the first speaker for this symposium. So Professor Nithushi Samaranayaka. Professor Nithushi Samaranayaka is a professor in the Department of Pharmacy and Pharmaceutical Sciences, Faculty of Allied Health Sciences, University of Sri Jayawardhanapura. She obtained her BSc Special Degree in Pharmacy from the University of Colombo with a first-class honors in 2004. She pursued her postgraduate education in Hong Kong, where she completed her PhD in medication safety at the Division of Clinical Pharmacology, Department of Medicine, Faculty of Hong Kong in 2013. She has been a pharmacy educator in the University of Sri Jayawardhanapura since 2009 and has a keen interest in training and research related to medication safety. Her prime aim is to develop clinical pharmacy services in Sri Lanka and ensure medication use without harm. So I cordially invite Professor Nithushi Samaranayaka for yours.
Thank you very much for that introduction. And I would like at the outset to thank the organizing committee of SLSCPT and Professor Galapathy for inviting me as a speaker today. As an academic pharmacist, I am honored to be in this forum. So during the next 15 minutes or so, I'd like to talk about what LASA or HAM are, and the prevalence and the clinical impact of LASA errors and related to HAM errors as well, and who needs to know about these LASA and HAM errors, and some of the strategies that we have used or people have used already and can use in order to prevent these LASA errors. So as you know, LASA means look-alike and sound-alike medicines. And if I ask somebody usually what LASA means, they'd probably tell me it's carbamazepine and carbimazole. It's probably because when we introduce LASA, you usually use this as an example, and some of them think it's just carbamazepine and carbimazole. But yes, it's quite right. This is a look-alike, sound-alike combination where carbamazepine or carbimazole, if it's written on a prescription or a label or on a drug container, looks very much alike, and also presumably sound the same as well if you give a verbal order. And if you dispense or write or prescribe or administer one instead of the other, it would cause a LASA error. So look-alike, sound-alike error. But they are not the only ones that are there in the list. There are so many combinations that can cause this confusion. And if you take it a little deeper, LASA names or LASA medicine name combinations can be generic combinations, where generic medicine names are similar, like clobazam and clonazepam, or it could be generic and brand names confusion, like dilantin sodium and diclofenac sodium. Usually doctors write it as dil sodium for both. And then brand name combinations like Losec and Lasix. Not only medicine names do look alike, but also medicine packages look alike. So here I have put some parenteral medication because that danger of confusing medication packages or medicines in parenteral medicines is far greater, but it happens in oral dosage forms as well. So if you look here, the two on the left are ephedrine and adrenaline. The middle one, ondansetron and phenylephrine. And on the other side, metoclopramide and ondansetron. If you keep them close to each other, they look very much alike. Not only that, not only medicine packaging, but the dosage form itself can be very similar, especially in a country like ours, where we use tender processes to get medicines. Our dosage forms or the medicines that we get change all the time. So if you look at the brown pill is diclofenac and bisoprolol, which looks very much alike. And the other one is glycoside and enalapril, again, very much alike. And to your right, you'll see different strengths of warfarin looking very much alike and could be confused. So in a country like ours, we might not have the standard colors that you have for the warfarin strengths, and they come in all the same colors. So, being human beings, all of us, and working in a habitual manner in a very, very busy clinic or a pharmacy or a ward, it's inevitable that we might pick up the wrong medicine if these look-alike medicines are kept together. How much are they prevalent? Are they very common? Well, this article talks about the prevalence. It's a systematic review, and it says of LASA errors are responsible for 6.2% to 14.7% of all medication errors. That's a considerable amount. The prevalence of LASA errors in prescriptions is 0.00003 to 0.0022, which you may presume is extremely small, but the same article reports that in UK they would expect 1 billion prescriptions, so 2.2 million LASA errors are expected in the UK if you calculate it properly. And in the USA, 1 of 4 medication errors reported in USA are because of name confusions. So this is the way, the prevalence of look-alike, sound-alike medicines in the world. And this is one of my experiences, actually, when I was visiting a ward. And I took this picture myself when I saw it, being interested in this area. And you see mannitol, dextrose, and normal saline stored here. And I asked, out of interest from the nurse there, do you think that you might, mix up or rather pick up the wrong one when you do so? And she was like, no, it can't happen. We usually check very well when you do that. So being human beings again, and habitual practice is to deny that error can happen, and we could pick up the wrong medicine with even the greatest intentions. Nobody intends to do it, but we deny still in our country that these kind of things could happen. And so I have some examples for you which have been reported related to look-alike, sound-alike errors. And if I am to read them, one is on mercaptopurine instead of mercaptamine administered, and the patient had pancytopenia but recovered. But the other three are more unfortunate, where one patient was administered methotrexate instead of mesalazine for diabetes, and the patient died after taking these medicines for a while. A patient was administered azathioprine instead of amitriptyline, and the patient died after some time. Then another patient was given methotrexate instead of metformin, and the patient died. So the last three, methotrexate errors and azathioprine, was reported in Sri Lanka, but of course it was not in a publication as I had in the first one. It was just in the news telecast or our own experiences, but they were not reported or published. So these are confusions of look-alike medicine names They can also confuse look-alike medicine packages, as I say, and the examples are hydromorphone instead of morphine. The patient was discharged and on the way home had fatal respiratory arrest. Then tranexamic acid instead of ropivacaine or bupivacaine, and digoxin instead of ropivacaine and bupivacaine. Seizures and ventricular arrhythmias in the former, and paraplegia and encephalopathy in the latter. And mind you, ladies and gentlemen, this was not just one case. There were 33 cases reported in this publication. And the next one is insulin instead of influenza vaccine. Today in the morning, my colleague was looking at my slides, and she said, how can anybody give insulin instead of influenza vaccine? Mind you, ladies and gentlemen, this is not one case, but 8 cases reported. So, look-alike, sound-alike medicines are dangerous, and it can impact badly on our patients, and it becomes worse if these look-alike medicines are high-alert medicines or high-risk medicines, as we say it. So what are high-risk medicines or what are high-alert medicines? They are medicines that have a higher consequence or a risk of bad consequences if they are used. So instead of any other medicine, if you confuse high-risk medicines in a LASA error, then the consequences are going to be detrimental. So it's important that we know what is LASA. It is important that we know what are the high-alert medicines. And if one wants to remember that in an easy way, we use an acronym, as even Professor Galapathy mentioned in her first talk, APINCHO, that is antimicrobials, potassium electrolytes, insulins, narcotics, chemotherapeutics, heparins, and other, for example, anesthetic agents and so on, would come under the category of high-alert medicines, and that too must be, as healthcare professionals, we have to be very, very vigilant on those areas. And I also came across a review article, a systematic review, and they reported the prevalence of high-alert medicines. As you would expect, it has a range because different studies use different methodologies. It ranged from 3.8% to 100%, and of all the medication HAM errors, 0.01% errors resulted in a death. So most of the time, you'd see international organizations alerting us on this. Usually when a case happens, the international organizations like ISMP and so on, they alert people on how you can confuse and go wrong. And who are these LASA alerts for? Actually, these LASA alerts are for all of us. Prescribers, it could be pharmacists, it could be nurses, and it could be patients. So it's important that we realize that all of us are human beings, and during our day-to-day practice, because of a confusion, we can do errors. And also we should be able to identify that the areas in which we can go wrong. So as prescribers, look-alike, sound-alike names become worse when you write illegible prescriptions. So that is how usually metformin and methotrexate get mixed up. And most of the time, there is carbamazepine, carbimazole errors, dilantin sodium, and so on. Another important fact to emphasize is that even if you use computerized prescribing or prescribing use electronic prescriptions, you will have a drop-down menu. And you have medicines lined up according to the alphabetical order. So one click and the wrong click right next to each other would be another medicine that you don't intend to give. And that's how you can mistake methotrexate, methadone, or something like that. So we have to be vigilant of that danger as well. I've seen transcribing errors by doctors because they might be transcribing medicines of the clinic card from the previous week, previous month to the next month, or they might be transcribing medicines, and I've seen this, from the BHT to the discharge prescription. And recently we saw error like that, cetirizine being written as cefuroxime. It's not rather very similar, but still it happened, it's quite similar enough, and that was experienced by us. So we have to be vigilant. Also, as prescribers, we have to be vigilant about the error-prone abbreviations, which we are not supposed to use. I won't be going into detail of that, but an example is microgram and milligram. You write that in a BHT or in a prescription with illegible handwriting, and you're inviting problems for the pharmacist and the nurse. And verbal orders is an important fact. I know prescribers can't avoid verbal orders. At times you have to do it, but sound-alike names become a problem when you have verbal orders. Pharmacists have to fill prescriptions, they have to pick up medicines from medicine shelves, and on the right side you'd see a desk of a pharmacist who's dispensing, and all the medicines lined up around, and most of the time it's in alphabetical order. So you end up all the close names right next to each other. So fill in the prescription, and when you're picking up a medicine, it is very likely that you will pick the wrong medicine if you are not vigilant enough, because the other one, which looks so much like that, is right next to you. And also transcribing onto a dispensing label, that could be a problem if you because of LASA errors. Writing medicine labels, when you're writing also, if you write it in an illegible way, that could happen. And also we must remember as pharmacists, and nurses, I would come to that later, that our medicines, because we buy through tender process, change all the time. Okay, so therefore, we have to be very, very cautious about that. And then nurses have to be also vigilant about administration and their ward stocks and the trolleys, because that too can cause errors as well as patients. So I think manufacturers and regulators must also be extremely cautious about that. Given the interest of time, I will just highlight the strategies that people have used to, just name them, people have used to mitigate these errors, having a LASA list and HAM list for a country-specific one. Then adequate separation of these medicines so that even if they are look-alike, they are separated enough. Then using tall man lettering to highlight the differences of two names, and using LASA or high alert auxiliary labels like this, and using technology. And most importantly, it's important to double check before you prescribe, dispense, or administer. As I couldn't explain much of the strategies in my talk, I would recommend you read the WHO guideline on look-alike, sound-alike medicines, resourced by Professor Galapathy herself, and that would explain much of the information in detail on how you could mitigate this problem in the future. Thank you very much.
Thank you very much, Professor Samanayaka. We'll move on to the next talk and take all questions at the end of the symposium. So have your thoughts and questions ready for Nitushi, and we'll take it at the end. Our next speaker is Dr. Lauren Walker. Dr. Walker is a reader in clinical pharmacology and therapeutics, an honorary consultant in general internal medicine from Liverpool, UK. Sorry. She co-leads the DNRX program funded by the National Institute of Health and Care Research, Artificial Intelligence AI in Multimorbidity Stream, and her research interest involves utilizing existing health record data to understand how multiple long-term conditions and their associated prescriptions evolve over time, and how these relationships between drugs and disease leads to harm. She is very interested in predicting risk and examining patient journeys to identify at what point the harm of a medicine outweighs the potential for benefit. She contributes to outpatient clinics, inpatient reviews, and multidisciplinary team meetings for adults with complex multimorbidity and polypharmacy. She is also the Deputy Director of the NIHR Clinical Research Facility at Liverpool University Hospital's NHS Foundation Trust and co-director of the Liverpool Early Phase Hub at the University of Liverpool. So over to Dr. Lauren Walker, to talk on rational de-prescribing to address polypharmacy.
Perfect. It's such a pleasure to get to speak to you all today, and thank you to the organisers for inviting me. So I tweaked the title slightly to medicines optimisation because that's a large bulk of the work that I do actually involves changing dose adjustment and even starting medicines quite as often as I stop them. So it's just to expand that. My disclaimer is I do quite a lot of medical education events that are sponsored by pharma, but they're non-product and not promotional. So we know that polypharmacy, the use of 5 or more regular medicines, is on the rise everywhere, but particularly in the UK, and we know that it's much more common as we age being the single biggest risk factor for long-term conditions. And that prompted a review in the UK called Good for You, Good for Us, Good for Everybody, which are strategies to tackle over-prescribing or the potentially inappropriate use of medicines. And we do see that is much more predominant actually in people from low-income backgrounds, and lower educational attainment. So that does present in itself a health inequality. And a person that takes 10 or more medicines every day is 300% more likely to be admitted to hospital because of an adverse drug reaction. And that has an enormous financial consequence for our publicly funded healthcare system. So I thought probably the easiest way for me to take you through some of the challenges around medicines optimisation is to tell you about a case, which is a patient of mine. It's not her real picture, but this is Marjorie. So Marjorie is 75. She's been pretty well the majority of her life. She is the main carer for her husband, though, who had a stroke some years ago and is bedbound. So her particular reason for review actually was tiredness, and she's sort of fed up of taking 18 medicines every day. She has high blood pressure and atrial fibrillation, for which she's anticoagulated because of her risk of thromboembolic stroke, and she had a tissue mitral valve replacement some years ago. Her lipids are not terribly well controlled, nor is her type 2 diabetes, and you can see on her biochemical parameters there that there's much to be done. She also, unfortunately, has COPD, so she has long-term emphysema as a consequence of passive smoking, actually, because her husband was a heavy smoker. And that's one of the causes of a lot of her hospitalisation. And she also had osteopenia diagnosed when she was in her 50s, so and then later osteoporosis, so she's a long-term bisphosphonate user. And this is the typical kind of example of the patient that I see in lists. We're kind of used to that now, a list of problems and a list of medicines. But actually, I prefer to view people through their journey. So this is what's happened to Marjorie over time, actually, over the last 20 years. And you can see that some of her latter problems are iatrogenic. So some of her admissions for acute kidney injury and things like that are probably compounded by some of the medicines that she takes, along with nosebleeds and things like that because of being anticoagulated. And it's just to highlight that she started bisphosphonate therapy in 1997. So I've adjusted some of the dates for this for this to work. So there are a lot of tools available to support medicines optimization, or to support prescribing, should I say, in the sense that we're incentivized to prescribe on the basis of risk. That's what helps us in our decision to start a medicine. So we developed a tool that's free to use, so it's a multi-morbidity risk calculator. So it's not a new tool, basically it just allows you to put the information in once and it will produce 6 different risk scores. Because one of the major challenges actually on the ground for doing medicines reviews is how long they take. Because to do 6 different scores, I usually have to open 6 different web-based systems and input largely similar data to all of them. So this will allow you to do that. So in a way, we're trying to save time in order to be able to direct that time to the patient interaction. And you can see that and this is very typical for the patients I see. Marjorie has a moderate risk of a thromboembolic stroke, but also a moderate risk of bleeding, and she has a 30% risk of developing ischemic heart disease over the next 10 years. So although she has lots of conditions now, they're not actually disabling. What we're trying to do is prevent her going on to have a more disabling condition. So this is what we call a structured clinical pharmacology assessment, a CPSA, that we do when we do medicines reviews in the UK. And one of the recommendations from the overprescribing review is that we should link conditions with their indication. And I can tell you from experience, this isn't terribly well done. And in people that are taking 18 regular medicines, you lose oversight around what was the original indication for the drug. You know, is that drug that's being used for heart failure now, for hypertension, also contributing to the heart failure management and things like that? So it's really important to connect those things. And one of the challenges is to then look for problems and solutions. So this is at the point in Marjorie's life where I think that there's lots that needs to be done to improve, actually. So that's why I call it optimization, because her blood pressure control isn't optimal. So I would want to look at it in the home environment, check that do some urine drug screening to make sure that she's compliant. I'm looking at things like warfarin. You know, this is a busy lady who has a lot of caring commitments, so could she be switched to something that doesn't require INR monitoring? I'm not a big lover of digoxin. It's a narrow therapeutic index drug. It causes problems as we age, so could we switch her to a beta blocker instead? So there's all manner of different things that we might think about doing. And one that I just wanted to highlight is we know she's been on a bisphosphonate for 12 years now. She's never had an osteoporotic fracture. And her DEXA scan, we'd get an up-to-date DEXA scan, was reasonable. So our national guidelines suggest having a bisphosphonate drug holiday for 2 years to reduce the risk of osteonecrosis of the jaw or atypical femoral neck fracture. So now I want us to imagine 10 years later. So I haven't seen Marjorie 10 years later, but this is us just imagining what might happen if we made some decisions. And this is the thing that we're keen to avoid, of course. So if I make a decision as part of the medicines review to stop her bisphosphonate therapy and give her a drug holiday for 2 years, the challenge always becomes in communication. So if that who's responsible for then restarting that drug 2 years later? And it's just to emphasize that medicines reviews are a long-standing process. They're not something that can be done overnight and then just abandoned. Because, of course, if Marjorie's bisphosphonate is not restarted, she goes on to have a fall and fractures her neck of femur. One of the things that stops people deprescribing at all is fear of litigious consequences. That was just one to highlight. But now Marjorie is dramatically changed. So now let's imagine she's 85. She has become severely frail. She's acquired other long-term conditions, including heart failure. She's having lots of hospitalisation, and she's always said she wanted to stay out of hospital. She's now immobile. She's lost her independence, moved into a care facility. And we feel that we're approaching the end of life. So now when we look at Marjorie's medicines, it's a very different approach. It's a very, very different thing that we're considering, trying to minimise the risk of her being hospitalised rather than minimise the risk of her developing subsequent conditions. I've highlighted warfarin there for us to think about. This is one of the major challenges. I do a heart failure, renal failure, diabetes medicine service. And one of the toughest challenges we have is around stopping anticoagulation in elderly, frail people at the end of their life. Nobody wants to do this because of the risk of, in somebody with atrial fibrillation, having a stroke. But of course, we have to counteract that with the amount of bleeding admission rates. So again, lots of, things are very different now. We know that the evidence tells us that particularly in the oldest old, so for people over the age of 85 with severe frailty, that tight control of your blood pressure might cause more harm than good, but that's a very individualized decision. And again, depends on what these medicines are being used for. I would probably, I am quite cavalier, I probably would stop the anticoagulant in this case if the patient was in agreement. And, there's lots of things to think about. Being on an antidepressant for more than 20 years, is there benefit in that? What's the safe point at which we can discontinue that? The other problem that I wanted to highlight here is her escalated cumulative anticholinergic drug burden. So she has a score of 8, and that's something that I would want to target, and we'll talk about that in the next couple of slides. But similar to her blood pressure control, her glycemic control is also probably too tight for somebody at this level of frailty. So I just wanted to talk about disease risk scoring. So we did those scores 10 years ago, and we're doing them again now. And largely, with the exception of the osteoporotic risk, her scores are the same. But Marjorie herself is has rapidly deteriorated and is significantly different. And as with all of these things, the decision to stop an anticoagulant is particularly challenging. And the challenge that I get from my cardiology colleagues is, but she's at very high risk of having a stroke. And she is, but it's all independent, it all depends on the individual. In my own area, living where she does, if she were to have if I stopped her anticoagulant and she had a stroke, she might be a candidate for thrombolysis or thrombectomy. Whereas if she has a major intracerebral bleed because she keeps falling over, there'll be nothing that I can do for her. So there is no situation in which there is no risk. There is always risk, but those risks compete with each other. And it's difficult to say that I have the right answer. So just a couple of slides before we finish on anticholinergic drug burden, because this is a major area of focus for medicines reviews. So these are medicines that are used to treat a really wide range of conditions. They target the rest and digest functions of our body, so everything that you should do after you've had a big meal. So by blocking that system, that's what leads to constipation, dry eyes, dry mouth, and urinary retention. And we know that taking lots of anticholinergic drugs, they can be numerically scored. So those that have a very strong anticholinergic burden score 3, those that are moderate score a 2, and those that where it's an off-target and an uncertain effect score a 1. And anything of 3 or above is an independent risk factor for dementia because of these drugs' effect on learning and executive function. One of the hardest things to identify, of course, though, for most prescribers, if you're not looking for this particularly, is how to surface these drugs that are harmful in a list of medicines that might be 18 drugs long. So I know that this person has an anticholinergic score of 11, but it's very difficult to see that because a lot of it is caused or contributed by drugs that are very commonly prescribed, and they have low burden individually, but it's that cumulative burden of harm. But they're all contributing to kind of the higher risk of falls and loss of independence. And the reason I highlight them is that there is something that we can do, all of us. So there are automatic calculators, again, for identifying this. I'm working on research that is trying to embed that into the clinical care record. But by targeting it and reducing it, then it might be possible to reduce some of the cognitive harm in those people that are pre-frail. But that hasn't been proven yet. It's caused by a lot of drugs. The ones I've highlighted in red are very, very commonly prescribed. So those, and they score 3 on their own. But things like prednisolone, furosemide, antihistamines, tricyclics all have some degree of anticholinergic burden as well. And there are things you can do. You can stop them. You can reduce the dose, although whether the impact of that theoretically should make sense, but when it's hard to know whether reducing the dose will improve things. Or you can switch them out, a high anticholinergic drug for a lower one. And I've been working with a group in Leeds in the UK to develop an automated calculator. So again, this would be embedded within the care record. So instead of you having to use a different system where you calculate the score yourself, it will highlight patients that have a high score. One of the things I'm very interested in is the impact of dose on that. So that's a study that we're running at the moment. So in summary, some of the take-home messages for how challenging this work is for medicines reviews, that visualization of the patient journey is really important for decision making, looking at those transitory steps between independence and a loss of independence, and trying to work out why something was prescribed, what's been tried in the past, and what's effective, is very time-consuming detective work, and we need tools that make that more efficient. Not all medicines reviews should necessarily lead to a reduction in medicine number. I think reducing the dose is important. I think changing one drug for a less risky alternative is also important, and sometimes we need to start medicines. So sometimes a medicines review will lead to an increase in total number. And there are useful calculators, and I showed you some of those, that help guide the decision to start a medicine. What we need now are risk calculators that allow you to stop medicines. So if I did this, then what happens? And we'll talk later in the day about the use of existing electronic health record data to be able to inform those kinds of decisions. What happens in people who stop? Because that doesn't really form part of the clinical trial evidence base. And I'll just leave you with the concept that there is never no risk ever. So you have to find out what matters the most to patients. We are, unfortunately, and I count myself among that, sometimes prone to saying, I want to start you on this blood thinner to stop you having a stroke. I want to treat your high blood pressure to stop you having a heart attack. It's not technically true. You reduce risk. We want to do these things to reduce risk. but we, in doing those things, often introduce a new risk, a competing risk. And so it's just important to weigh those things up together. And a big part of that in the future is how we explain or communicate that risk to patients who have differing levels of health literacy. And thank you so much for your very kind attention.
Thank you, Dr. Lauren Worker, for your excellent presentation. So we will take up the questions at the end. So let me introduce our third speaker, Professor Chamila Mithananda. Professor Chamila Mithananda, MBBS, MD, PhD, MRCP, is a compassionate clinician and an academic. She completed her postgraduate training in acute general medicine at the John Radcliffe Hospital, Oxford, UK, and stroke research at the Nuffield Department of Clinical Neurosciences, University of Oxford. She is a board-certified specialist in general medicine and is currently a professor in the Department of Pharmacology, University of California. Her research interests are cardiovascular epidemiology, stroke, diabetes, and clinical trials. She has numerous publications with over 2,600 citations. She is a fellow of the Royal College of Physicians, Royal College of Physicians of Edinburgh, American College of Physicians, and Ceylon College of Physicians. She served as the Joint Secretary of the Sri Lankan Society of Internal Medicine, the Joint Secretary of the Ceylon College of Physicians, and Secretary of the Specialty Board in Clinical Pharmacology and Therapeutics at the Postgraduate Institute of Medicine, and the Secretary of the Sri Lankan Association of Clinical Pharmacology and Therapeutics. Over to you, Chamila.
Thank you, Tilanka, for that kind introduction. So at the outset, I would like to thank SLACPT for giving me this opportunity. So actually, I'm going to talk about medication reconciliation, which is not a well-established concept in Sri Lanka, though we do it time to time. Right? So first we will see what medicine reconciliation is. So this is the process that facilitates transfer of accurate and complete patient's medication information at interface. So be it somebody coming from home, getting admitted to hospital, or somebody getting transferred from a ward to another ward, or somebody getting ready to go, getting ready to get discharged back home. So we have to get them an accurate and complete patient's medication list. This is called medication reconciliation. This is a very important key aspect in medication safety. This is especially important in Sri Lanka because now it is not very costly to see a specialist in Sri Lanka. So Sri Lankans do visit a lot of specialists. So the heart is looked after by one consultant, and the liver is looked after by the hepatologist. Then the kidney is looked after by the nephrologist. So reconciliation of medications is very, very important, especially in Sri Lanka, because with that, they are so there is limited time that they spend seeing patients. So reconciliation of medications is not always done by specialists. So this is not a, if you take countries like UK, there are specialized people, dedicated people to do medicines reconciliation. So there is a clinical pharmacist in the ward who's doing this job. But it's not the job of the pharmacist only, it's the doctors, the nurses, and everybody. It's a multidisciplinary team's approach that will bring up the best outcome. Now, why it is important? We know, so the main reason is to avoid patient harm. So we have seen quite a lot of disparities in the medications prescribed and unintended medication errors due to two main reasons. One is you do your job, but it is not communicated to the patient and the caregivers. That is one important aspect. As well as there can be inadvertent information loss. So we'll say somebody was on warfarin and it's the most junior doctor who's writing the discharge medications, and if
that due to some reason, if warfarin was not taken to the discharge medication list, the consequences could be very dangerous. So to prevent this, we do not have a specified person to do medication reconciliation in Sri Lanka, but it is something that we need to bring up into practice. So we have clinical pharmacists and we have clinical pharmacologists. So I think that is something that need to come into Sri Lankan setup. So unintended medication discrepancies are common, even in the Western world, like in the developed countries. So these discrepancies can be according to a recent publication, so the worldwide, the prevalence it could be 67% even. But the good thing is all these 60% does not give rise to patient harm. So the clinically significant discrepancies are lesser compared to this, but still there is some patient harm that is caused due to these medication discrepancies. So what's the benefit of having medication reconciliation? The main aim, they have shown that it is possible to reduce significant unintentional medication discrepancies. Clinically significant discrepancies can be reduced by about 34%. So that is a big improvement. But we have to remember the one important thing is if we make a mistake in the medication reconciliation process, that can become hardwired into the patient's records and that can be repeated. So it is important, it's not the most junior doctor in the ward who need to do the final discharge drugs planning. So it needs be gone through, somebody senior also should look into the discharge medication list. Now, what should we do as medication reconciliation? So there are two things minimum that need be done. One is, the most important thing is completion of a best possible medication history. And the second thing is, it's no point just taking the history only. You have to correct any unintended discrepancies. And these changes need to be communicated to the patient and the healthcare providers. Otherwise, there is no point you doing the job, but it is not communicated. The final outcome is not good. But in more advanced medication reconciliation, it is good, because it's a multidisciplinary collaboration is important. Interpersonal, discussions, collaboration is needed. It's not only the doctor who's doing it, should discuss with the nurses as well as the pharmacists. So it's a collective process. And then these medication reconciliation, the final discharge summary should be integrated into their final prescriptions, the discharge, the summary that we are providing, and counseling the patient about the changes is important, as I highlighted before. So this can be bundled with all the other interventions. So it's in developed countries, so they have discharge care planning, they advance plan the care. So whatever the planning that we make, not just for 1 month, but for the if somebody is 85 years, just planning a month is not what need be done. So we have to plan it for future. So discharge care planning and follow-up appointments, and then post-discharge follow-ups for everything. For everything, the reconciled medication list should go with that. And then coming to the most important thing in medication reconciliation, the number one thing is like we have to take a best possible medication history. So what is a best possible medication history? This is a comprehensive history than a routine primary medication history. Right? It involves two steps. One is like we have to like use a systematic process for obtaining a thorough history. Like we have to start with like prescribed medicines, non-prescribed medicines. Likewise, like we have to go in an order and cover all the medications that the patients are on. And then verifying those with at least one reliable source. Going through the clinic book, because a lot of patients do have several prescriptions given by several specialists. So you have to go through all those, the clinic book and whatever the other prescriptions that they are having from the cardiologists and the nephrologists likewise. And then some hospitals in Sri Lanka do have now electronic medical records. But if we do have those, or if not, we have to go by the paper records we have. We have to combine all those and to verify and then come up with the best possible history. Now, this is the overview of medication reconciliation, right? So, if we start like a patient coming, we'll say patient is coming from home and to get admitted to a hospital. So you start with the admission reconciliation. There what you need to do is you do an extensive interview of the family and the patient, and then you look at all the medications, all the records they have, what medications they are taking, and if we do have, we can go through electronic medical records and previous all records, and combining all those, we come up with the best possible medication history. And then you plan the acute medications according to that, it's the add-on things to the best possible medication history. Once the patient is decided to be discharged, then you have to do another discharge reconciliation where you again combine and look at the best possible medication history as well as the new drugs that were added during this acute hospital stay, and then you come up with a best possible medication discharge plan. Coming up with that is not adequate. This need to go with all the discharge summaries and all the documents that you send the patient with, as well as it need to be communicated to the patient as well as the caregiver. So there are 5 steps that we need to follow when we are making this medication reconciliation. So one is list the patient's current medications. This is the easiest. So we find the current medications and then list the medications currently needed in this acute setting, right? And then you compare the lists and see whether there are counteracting drugs, repeated drugs, and maybe somebody is on 2 calcium channel blockers given by another specialist and the second one by another specialist. So likewise, you have to compare the 2 lists and then make a new list based on the comparison, and then this new list should be communicated to the patient. Otherwise, patient will be taking everything that he had been taking before as well as the current medications. So how do we do this medication reconciliation? So that so it's not, the whole world is working on this because this is an important aspect. So there are several forms developed, checklists, toolkits available. So Marquis tool and then WHO High 5S project tools, and then there are online tools to do that. And this need be not done only at one time. Like, I mean, on admission it need be done, and at least at discharge, the reconciliation need be done. If I tell you quickly how to probe for a best medical history, so you have to start with an open-ended question, like you ask, what medication do you take, right? And then after that, go for the PRN medications, when necessary medications that they are taking. And then you can ask like specific questions like, how often do you take something for pain or allergies or heartburn, or like you can ask the patient. And you can fill the gaps in between, like maybe somebody is taking paracetamol 6 times a day. That is possible if they do have pain. So likewise, whether the doses are actually the correct, what they are taking. And then you can ask, like if somebody is having a wound, do you take anything for the wound? Then only they will come up with the things that they are taking. And then you can ask about specific conditions. So if somebody has diabetes, what do you take for diabetes? Then they will come up with that history. And also, like if you ask any probing questions, like there are things that they forget to tell, eye drops, inhalers, those things you have to ask specifically whether you take any of those, then only they'll come up. You can ask them like, are you taking any special medicine at night? Maybe they are on sleeping tablets, but that they don't come up at the beginning, saying at the beginning. Then ask about non-prescription products that they take, and especially in Sri Lanka, like herbal products, like a lot of other medications that they take. Right? And then it's important for us to know, like when was the last dose of each medicine was taken. Like, I mean, maybe somebody was prescribed alendronate, but then they have not taken it for last 3 months. So that is a possibility. So you have to probe into that as well. And finally, adherence is an important thing. So you have to ask, like during last 1 week, how many times did you miss a dose of medicine? That is the easiest way to ask for adherence. So we have to take a best possible medication history. Now, this is like, I mean, so medication reconciliation is well established in other, like especially in the low, high-income countries. But how can we like implement it in low-resource settings, right? Yes, it is a challenge because we have less, like, I mean, so there is inadequate coverage of health costs per patient in low-resource settings. So like we have like very few pharmacies for the whole hospital, and there are a lot of thousands of patients coming to the hospital. So likewise, even the nurses and the doctors, the ratio of doctors to the patients is low in our country. So that is a problem. And the other thing is like the infrastructure. So we mostly rely on paper records, and we don't have electronic health records to easily look through. So those are the challenges. However, we can do it in low resource settings, that because it is a very important aspect in patient safety, we have to do it somehow. So if we don't have digital records, we can go by paper records. We have been doing that all this time. It is just to like pay more attention and do it in a proper way. We have been doing, like some doctors do go through all the prescriptions and make a list, whereas some, they are not bothered to do that. So likewise, we have to do it. And then because now it's in our practice, like the pharmacists are not, we don't have clinical pharmacists in the wards in most of the places. So this is, if at all, is being done by doctors only. So I think, like, I mean, so it is another need that for the country, that we need to have clinical pharmacists and clinical pharmacology doctors in the wards, so that this the process we can start and continue. And other things like, so once we do a medication reconciliation, we have to transcribe it into a paper, and we have to if we can put it in a like a colored paper or so and put it in patient's notes, and then the patient also can go and give, when the patient seeks advice, seeks another healthcare provider, the patient can show that to the healthcare provider, so it becomes easy, and the double work is then the workload is reduced. So in UK, the clinical pharmacists, they do write in a green pen in the drug chart. So something like that, we have to start doing something so that green pen is only for them, and so we know that it's the pharmacists, clinical pharmacists have gone through it and made recommendations. Finally, the other problem I said to implement in low resource settings, the problem is we don't have resources and time to go through all the patients. So in that situation, the most important thing is we have to re-stratify patients. So everybody, if somebody cannot give us, I'll finish in 2 minutes. Yeah, if they can't give a history, give us the medications that they are on, or if they are on more than 10 medicine, or if they are on high-risk medicines, they are at high risk. Those are the people that we need to prioritize to reconcile medications. So, so in summary, ladies and gentlemen, so medication reconciliation is a vital a concept, and it is to reduce patient harm. It reduces clinically significant medication discrepancies, and then we have to involve multidisciplinary teams engaging at different stages, and best possible history taking is the starting point, and communicating the final list to the patient is important. And in poor resource settings, we have to go with the at least re-stratify patients and do it only in high-risk patients. Thank you.
Thank you, Shamila, for that very interesting lecture. Ladies and gentlemen, we have come to the end of the symposium. Since we are running behind time, we will not be able to entertain any questions, but I'm sure the speakers will be happy to answer any queries that you have during tea time. So on behalf of the SLA-CPT, I'll ask my co-chair to hand over the certificates of appreciation to the 3 speakers, Professor Nithushi Samaranayaka, Walker, and Professor Shamila Methananda.
Thank you for that comprehensive symposium. Now let's take a short break for tea. We will resume at 11 a.m. Thank you.